Hi, everyone. I want to thank my colleague, Dr. Katsiktis, who helped me with this presentation, and my program director, Dr. Antonavicius. We don't have any conflicts of interest to disclose. So the reason behind doing this database analysis was as robotic surgery becomes more commonly used, and specifically, there's been advantages in terms of ergonomics and operating in patients that have thicker abdominal walls. It has been more commonly used, particularly in bariatric surgery, as well as operating in small spaces, such as and the hiatus gives a benefit. And as on the other hand of the coin, on the other side of the coin, we also wanted to address the issue that there hasn't been enough data in terms of comparing the safety and efficacy of the beta-pancreatic duodenal switch with, of that duodenal switch in terms of robotic versus laparoscopic approach. And so we went to the MBSIQ registry. We collected 4 years of data to analyze the comparison between robotic and laparoscopic outcomes. We used a primary code for the duodenal switch, and we included any adult patient that underwent the procedure. We divided them into, again, the two groups, robotic and laparoscopic, and we excluded patients that had this procedure as a revisional. So patients that had prior sleep and then performed the switch, those were excluded. So we actually found several different discrepancies in terms of the demographics, the distribution of the patient population. The first one is, even though there's a small difference between the average of the age of the patients, it ended up being a significant, statistical significant difference, even though you can see it's like less than a year and a half on average between patients that were in the robotic and the laparoscopic group. Most patients were female, evenly distributed amongst both groups, and for both groups as well, most of the patients were Caucasians, but there was a predominance in terms of the patients that underwent the laparoscopic procedure. The average weight was pretty evenly distributed, just south of 200 pounds on each group. And another difference was that even though, again, there's only 2-point difference, or less than 2-point difference amongst the BMI, there was a slight tendency of a higher BMI that was significant in terms of the patients that underwent the robotic procedure. Other differences that we found that were very interesting was, as you can see on the right side, most of the patients' significant comorbidities were highly more prevalent in the laparoscopic group. You can see in terms of the reflux, it was almost twice as high, even though we don't have an explanation on why, but there was twice the rate of patients that are going before the procedure, whether it was therapeutic or diagnostic, a cardiac catheterization, as well as almost twice the rate of hypertension, slightly increase in patients being actively smoking prior to the procedure, almost twice the rate of COPD, and an ASA score that was 4.4% higher on the laparoscopic group, but again, going along with this line of comorbidities, meaning that patients on the laparoscopic group were actually unhealthier than the patients in the robotic arm. Some of the other things we found as well was, sorry, let me go back to that one. Yeah. In terms of the outcomes, actually, there were, we didn't find any significant difference for most of the negative outcomes. For example, just to mention a few ones, in the 30-day post-operative period, AKI, wound infection, whether it was deep surgical site or superficial infection, sepsis, pneumonia, DVT, and pulmonary embolism were actually pretty low. You can see overall there are less than 1% of complications on almost every single morbidity effect that are listed over here. However, as we keep going down, the terms of significant negative outcomes, we end up finding that oh, sorry, I don't know why that happened. The circles on the bottom are wrong, sorry. The patients actually ended up going more, undergoing more unplanned ICU admissions when they underwent the laparoscopic procedure versus the robotic, as well as there was a slightly 3 times the rate of 30-day patient mortality in the laparoscopic group comparing to the robotic. There was also, of course, the tendency of the robotic OR time being lengthier than the laparoscopic. It was almost twice as long, as you can see, and these variables were actually statistically significant. So the conclusions we can make, there's several limitations to these conclusions that we have to take with a grain of salt, but overall, both laparoscopic and robotic approaches are actually pretty safe. The morbidity and mortality is actually pretty low in the first 30 days after the procedure. There's a skew in terms of the patient selection. There's a bias. Some patients ended up being on the unhealthier side when it came to the laparoscopic arm. And there was also some operative longer times with the robotic. I do have to say that this database was from 2015 to 2018. And most of these patients most likely underwent robotic procedures through the SI robot, which you have to undock, reposition. There's less versatility in terms of how you do the operation compared to the XI system. So I think that had also a contribution in terms of the length of the procedure. And of course, there's a learning curve as more people use the robot. It should be a more efficient procedure. And that's basically what I mentioned in the other slide. Thank you.